Welcome to The Developing Doctor, where we explore the stories and strategies of physicians who are reclaiming the heart of medicine and building sustainable, fulfilling careers. I'm your host, Dr. Ben Ranking, and today we're kicking off a series of episodes where we explore conversations with physicians who are charting their own paths. One of the most common things I hear from physicians is that I really love being a doctor. I just can't keep doing it this way, and I want a little bit more control, and I'm just not even sure where to start. And the only way we can figure out what else is possible is by listening to the people who are charting those paths. So, my guest today is someone who fits that bill. Dr. Frank Okosun is a board-certified internist, medical director of Brazos Primary Care Associates in Lake Jackson, Texas, and a clinical assistant professor at Sam Houston State University College of Medicine. He's also a past president of the Brazoria County Medical Society. Here's what makes Frank's story worth a little bit of your time. He didn't start out in Texas. He actually started out in Nigeria at the University of Benin Faculty of Medicine. He completed residency in the U.S. at Meharry College of Medicine, or medical college, and he spent a decade as a medical director in a busy primary care practice. And now, after all that he's accomplished, he's making another big pivot as a primary doctor can make. He's launching an MDVIP affiliated practice. So, Frank, welcome to the podcast.
Well, thank you for having me, Ben.
Yeah, it's a pleasure to have you here. And I think with that little introduction, I'd just love to hear about your story in your own words. So, how did you end up in the spot that you're in right now?
Oh, for sure. So I'm a board certified internal medicine physician. I've been a physician for 20 years, private practice 11 of that 20 years. I see patients for a variety of conditions, primarily see adults. I see very complicated patients, patients that a lot of times nobody else wants to see. So patients with difficult to control hypertension, diabetes, COPD, stroke, heart failure, peripheral vascular disease. I enjoy internal medicine. And one of the reasons why I chose to do internal medicine is for the variety of cases that you see. Initially, earlier on in my career, I was looking to specialize, but I couldn't really pinpoint a particular area that I wanted to do because I loved everything. I love going from one room, you're dealing with somebody that has depression and anxiety, so you're going to another room and somebody's having hypoglycemia due to their insulin-dependent diabetes. So there's a lot of information, there's a lot of medications and things to keep up with. About 30 to 40% of the medications I use right now were not available during my residency training or even during medical school. So I love staying on top of current information and making my patients feel better.
So it sounds like you follow some really complex patients, and I suspect are a really busy clinician. Was there something in your in your life that prompted you to sort of even go down this path in the first place? Like, why choose medicine? There's so many paths that someone who's hardworking and intelligent can follow. What pulled you to medicine?
I love to solve puzzles. And a lot of times I might be sleeping thinking about a problem. And in the middle of the night, I just grab a piece of paper, I go to the computer and I put down some thoughts as they come to me. So I love dealing with complicated cases, helping people feel their best. My mom, when I was 5 years old, my mom is a nurse. When I was 5 years old, she told me that I was going to be a doctor because she said she noticed that I love helping people. I love being altruistic and even sacrificing myself just to see other people do better. And seeing people at their best, it gives me immense satisfaction.
It's that combination of challenge and altruism is sometimes hard to find anywhere else, and medicine kind of checks both of those boxes for many people. What was it like? About 25% of the US workforce is trained at some point in their training internationally, so graduated from an international medical school. And I don't think that's something that many people in the public realize, is that we're really dependent upon people who've trained in foreign medical schools. Can you talk to us a little bit about that transition from training in Nigeria to coming to the US?
Yes, I will have to say it was more of a culture shock because in Nigeria, a lot of the emphasis is on tropical diseases that are not really very common here. Things like tuberculosis, malaria, typhoid, diarrhea, that are really not common here. And there's more emphasis on clinical skills and clinical acumen because you are in a resource constrained environment. So a lot of times we were taught clinically to diagnose pneumonia at the bedside by percussion and by auscultation, and also to diagnose ascites by doing auscultation and percussion methods. But over here, when you say, oh, you have a patient with shortness of breath and all that, the first question somebody asks, oh, what did the CAT scan say? What did the chest x-ray say?
Yes, yes,
Yeah,
yeah.
so it's a little bit different there. There's a more emphasis on clinical acumen and clinical bedside diagnosis of conditions. So it was a little bit of an adjustment. And then you start to have to learn a lot of new diseases that are not prevalent in Africa. Things like C. diff, fungal infections, the flu, more difficult to control diabetes, obesity, things like that, COPD, because obviously you have more smokers and people with chronic lung disease. So it was definitely a challenge and a sharp transition, because you kind of have to bring along your clinical acumen, but you also have to be willing to learn new information and more diseases that are non-tropical, that are more common here in the United States.
Yeah, I think the culture shock piece is something that I've noticed a lot in our residents and fellows who come and train at the university I work at, where it's not just the medicine that's difficult, it's just learning to work in a new system. But I like that you highlight something that I've seen again and again is sometimes there's some skepticism when a patient meets someone who's initially did part of their training in a foreign medical school, but frequently there's such a deep skill set that the US trained physicians no longer have because we are so dependent on our technology. But physical exam and taking a history and being able to diagnose things by looking at a patient is so important. And I have learned that and been humbled time and time again when a resident or fellow who's trained elsewhere comes and tells me, hey, this patient has X, Y, or Z. And I say, are you sure? Let's get a chest x-ray. And they're always right. So I think that's a really important point to highlight is the skill set that our colleagues bring to the table.
For sure. And then another thing too is that back in Africa, doctors are so highly respected and highly regarded. So a lot of times when you're talking to patients, you are really telling them what they're going to do and not really getting input from them or getting an idea of, hey, what do you think about this? Or what is this going to happen? The doctor just says, okay, we're going to do X, Y, Z, and X, Y, Z is what happens. You really don't get a lot of pushback or people saying, oh, I want to really think about this, or how about I read up on this. But times are changing and patients are becoming more knowledgeable and are advocating for themselves better. And you have to know how to respect patients' wishes. Even though you think it might not be in their best interest, you have to accept their wishes, especially if they are competent patients.
Yeah, there's so much information at our fingertips, like you said, and shared decision making has become more and more important in medicine. And I think you're exactly right. It's a challenge in pediatrics where I work, and I can imagine in adult medicine it's equally so. One of the things that I noticed is that you've really worked in multiple different settings. So, you work in an outpatient clinic. It looks like I think you've spent time as a hospitalist. You've worn an administrative hat as a chief of staff in a community hospital. And, what have you learned about those different settings? And does the perspective of being a frontline clinician and then also being an administrator, how did that change your perspective about the healthcare system?
Some shape or form, I've always been a leader and had administrative roles. In my residency, I was the vice president of the House Staff Association. So people come to meet me when they have problems and they're expecting solutions. So from an early age, I've always been a leader and taking initiative in dealing with issues. So one of the things that drew me to internal medicine was that I was able to follow my patients through the continuum of care. So when I started out my career, I was doing traditional medicine. So when my patients were sick in the hospital, I got to follow them in the hospital and follow them through the course of their stay in the hospital, and also follow them when they got discharged from the hospital. So there was a continuum of care where they were seeing the same physician who knew them over time. So a lot of these patients, I didn't need to open computers or open charts. I kind of already knew what was going on with a lot of them. But unfortunately, with the advent of electronic medical records and meaningful use measures, it became more difficult to follow these patients in the hospital. So I had to give up my hospital care and allow the hospitalists to provide those services for my patient. I still keep my privileges though, and from time to time, I still go to the hospital to see patients or talk to specialists or doctors in the hospitals about my patient and the plan of care. And I'm also able to log in and track their progress when they stay in our local hospital facilities. So it's a lot of hacks. You have to be ready to go at any time. As the County Medical Society president, I had good relationship with the local physicians. I will go and talk to them and find out what their challenges are, both in private practice and as hospital employed physicians, and see how we can empower them and help them overcome any challenges or obstacles that they might be facing with their local hospitals or insurance companies or credentialing entities and things like that.
You're echoing a lot of pain points and issues that people deal with regularly. And I think one of the things that I've heard from my parents' generation, especially, is they're used to the time when they saw the same doctor all the time, right? So in the clinic and in the hospital and for follow up appointments, and there's sometimes a perception that it's the physician's desire to not wear all of those hats and not practice medicine in that way, but commonly it's actually systemic constraints like you're talking about, where it's just impossible to do all of those things and provide good care. I think it's an issue that many of us have struggled with at some point.
That is correct because, like I said, with the advent of electronic medical records and meaningful use and JCO standards, normally back in the day, you had 24 hours to do a history and physical on a patient who has been admitted into the hospital. But now, with time, those guidelines have changed. Depending on the diagnosis, now they want you to have a history and physical within 4 hours of a patient being admitted into the hospital. If you have a full outpatient scheduled clinic of 30 to 40 patients, it's difficult to drop everything and run to the hospital to get that history and physical done within that 4 hour timeline. Or if a patient has a myocardial infarction and you have to sign in orders within an hour of giving it. If you're at home and the patient gets admitted 2 o'clock in the morning, are you going to drive to the hospital at 2 in the morning, go sign the orders, go back home, try to sleep, and then go back to the hospital in the morning before you go and take care of your full clinic schedule later on in the morning? Yeah, it's just unrealistic and unsustainable. And then something will have to give. Either the physician will get burnt out, which happens a lot of the times, or you start to give substandard care.
So I think that's a good point to pen to pivot, is you're making a big change here. And it's one that I know I've heard physicians talk about. And so, people have heard of probably concierge medicine or membership medicine, but the terms are used loosely and I'm not sure that everyone knows exactly what they mean. So for someone who's hearing about MDVIP for the first time, or these terms for the first time, can you explain what that model actually is, and what does it look like? What does it do for you and the patient?
Yeah, so you're very correct, Ben. I've heard a lot of these terms being used loosely, interchangeably, but they mean totally different things. And because these are still very new models, when you consider our healthcare system as an overall, it's very, very important for people to understand the distinct differences between these models. So I will start off with the direct primary care model. That has been gaining a lot of traction and popularity in the last couple of years. So with direct primary care, it's basically a membership-based model where clinicians under that model, they do not take any kind of insurance. So they are not credentialed with insurance companies. They do not accept insurances. So each member pays a fixed monthly amount that covers doctor visits. In some practices, depending on the setup, it might cover medications in states that allow clinicians to dispense medications. It could cover labs. It could cover basic office-based procedures and things like that. So in that model, they don't bill insurances. They are not credentialed with insurances. And then you have the concierge-based model. So in the concierge-based model, patients have insurances, but they pay a annual or monthly retainership fee for improved access to the doctor. So they get the doctor's direct information. The doctor is available on nights, on weekends, get access to same day or next day appointments that are longer in duration, not the routine 10 to 15 minute rushed visits. So in concierge, they are paying for increased and improved access to their clinician, same day, next day appointments, after hour accesses. NDVIP is a little bit different. You get the best of both worlds, but it's not technically direct primary care model, or it's not a concierge based model. In MDVIP, you're basically paying for enhanced testing because unfortunately, the model MDVIP means the VIP stands for value in prevention. Unfortunately, our healthcare system right now is basically based around reactive care and not proactive care. So there are a lot of advanced testing and advanced screenings that we have available to us right now, but the healthcare insurance companies are not covering them because they said they are not medically necessary or they are still experimental. We're still using lipid profiles from the 1950s and 1960s that just basically measures HDL, total cholesterol, and LDL. When we have more advanced lipid screens that can give us more information. So the studies have shown that 40 to 50% of patients who have a normal lipid profile with the old system of checking just the total cholesterol and the LDL and the HDL, 40 to 50% of these patients still go on to have a heart attack and stroke. So what that tells us is that there are certain things that we are not checking for that we should be checking for. So with our testing, we do an advanced lipid profile that includes things like lipoprotein A, apoprotein B, apoprotein A. We do markers that tell us inflammation. The studies have shown now that two big drivers for cardiovascular events are inflammation as well as insulin resistance. So right now, we are barely just checking for hemoglobin A1C and determining if the patient is pre-diabetic or diabetic. When there are tests that can tell us at the earlier stage when a patient is insulin resistant, and we can jump in at an earlier stage and start to reverse the process instead of waiting for them to become pre-diabetic and diabetic. So right now, with a lot of our diets, we know that inflammation is on the rise. We're eating a lot of processed foods that cause us to have a lot of inflammation. So that's why a lot of inflammatory diseases are on the rise. Diseases like rheumatoid arthritis, lupus, psoriasis. And in my experience, a lot of those patients who have these inflammatory diseases, they are 4 to 5 times more likely to have a adverse cardiovascular event because the inflammation is not just happening at the level of the skin or the joints or the kidneys. They're unfortunately also happening at the level of the blood vessels. And when the inflammation levels are very high, the inflammatory levels are really high at the level of the blood vessels, their risk of having plaque rupture and having a adverse cardiovascular event is very, very high. So we do a comprehensive executive level physical from head to toe. So they will have advanced vision testing done that will determine if they are able to drive at night, determine their night vision, determine their close vision, their far vision, their peripheral vision. So we can start to find out issues in their vision before they become bigger problems like having macular degeneration or having glaucoma and things like that. We do pure tone audiometry testing to check their hearing because hearing problems are on the rise, and people, unfortunately, in my experience, they don't want to go to the ENT because then that will signify that they are old and now they need hearing aids and things like that. So we are bringing the ENT to them and doing this testing. We will do spirometry, pulmonary function tests. We're seeing a lot of lung problems in people who are not smokers, but due to environmental exposure or secondhand smoke, we're seeing people develop lung issues, even though they weren't smokers, but they might have been exposed to chemicals in their job or secondhand smoking due to a spouse or family members. We're seeing patients who are having a reactivation of their childhood asthma. So these patients with this pulmonary function testing, we can get up-to-date information on the state of their lungs. We also do a EKG on all our patients annually to see what's going on with their heart health. Make sure they don't have any arrhythmias, they're not having any signs of cardiomegaly or any other heart problem. We do an ABI on all our patients, ankle brachial index on all our patients as a standard every year so that we can rule out any peripheral vascular disease. Peripheral vascular disease, unfortunately, is on the rise, and a lot of times it's not detected until patients has advanced disease where they are at the point of either having a foot amputated or having their toes amputated. So especially in high-risk patients, patients above 50, smokers, diabetics, patients with known cardiovascular problems, patients who have chronic kidney disease, chronic liver disease. These are patients who are at high risk for peripheral vascular disease. So we screen these patients, and patients who screen positive or who have abnormal ABIs, we are able to refer them for further testing and intervention if necessary. We also do a grip strength test to see if they have any possible markers that can tell us if they are developing any neurological disease, possible tremors, muscle wasting, Parkinson, stroke conditions, and things like that. So we do a series of about 18 tests on these patients to screen for all these different diseases. We do questionnaires to screen their sleep health, to screen their sexual health, to screen their mental status, and also their psychological health as well, to see if they have any issues that deserve further testing or evaluation. And then after all these tests are done, the blood work includes a hormonal panel as well as markers for inflammation. Those tests go out to Cleveland Heart Lab in Cleveland, Ohio. Cleveland Clinic, they are known to be the best in cardiovascular health. They are one of the top 3 programs in the nation. So when we get all these results of this testing back, then I sit down with each patient for an hour and a half and go over all the results of all this testing and come up with an individualized, personalized wellness plan for those patients. Another important test we do is a body composition analysis that we do to screen them and see how much good fat they have, how much bad fat they have, how much muscle mass they have, because that's very important, especially for a lot of patients who are currently on GLP-1. They are very excited. They look at the scale, oh, I'm losing 50 pounds here and 60 pounds here, but they don't realize that a lot of the weight they are losing is muscle mass, which they need, is very important for their metabolic health. So with that body composition analysis, we are able to monitor them and make sure that they are not losing too much muscle mass. And if they are, we'll start to make some interventions either in their diet or in their medication treatment protocol to make sure that they are losing more of their visceral bad fat and they are not losing any of their good fat or any of their muscle mass. So with this program, what the patients are paying for are this advanced testing. And we still do accept insurances because as much as we hate insurances, we all still need insurances for catastrophic events. Unfortunately, people get diagnosed with cancer and chemotherapy might cost hundreds or thousands of dollars, or people have an accident and they need 10 or 12 different surgeries. But that is kind of where healthcare is going to now. It's more for catastrophic events and not for day-to-day medical care to keep you in your best shape and to prevent further illness. What I tell my patients now is when you do carry car insurance, but if you need a new tire or if you need an oil change, you don't call your car insurance companies and say, hey, I need my oil change or I need my tire change. You go ahead and do it. But if something happens and your car gets stolen, or you're in a major accident, then you call your insurance company to step in and help you get through that situation. So that is where healthcare is moving towards now. We are seeing deductibles go through the roof, out-of-pocket costs, co-pays, and everything is just going astronomically high. So for patients who are looking to be in their best health and prevent a lot of these cost expensive medical problems from coming on, they have to look into options like these to stay healthy. Because going into a hospital for diabetes or congestive heart failure exacerbation or for a stroke, that can easily cost $18,000 to $20,000. So I know with these programs it's an additional cost, but if you look at the amount of money you're saving, because even if you go to the ER for a UTI or cold and flu or something, that can easily be a $3,500 or $4,000 bill. And then a lot of times you're seeing somebody who really doesn't know you, who has about 5 to 10 minutes to figure out what is really going on with you. So that is really a risk that you're taking when you can have access to a physician who has known you for a long time after hours, who can really figure out what's going on with you and let you know what you need to do.